The mother was informed that the child was born at full-term vaginal delivery. She cried at birth. There were no significant post-birth medical history. The patient was discharged. After a few weeks of birth, the mother noticed hurried breathing, chest injury, and failure to thrive. She also said that there was some type of history present, and this prompted her to take her to a local pediatrician, where he examined her and scan was done, and the mother was told that the child had a hole in her heart. He also said that there is no requirement of any surgical intervention at this point, and she should be kept under follow. During this period, the mother said that there was increased frequency of lower respiratory tract infection in the form of frequent cough, fever, which required hospitalization, and the child was recovered after administration of some injections. These episodes were at least 1 to 2 episodes every 6 months. She also noticed that there was poor weight gain compared to her peers. So the mother took her to the pediatrician again, this time at the age of 5. And the patient again underwent an echo, and she was told that the child needs a test before the treatment, and she was referred to a higher center. The patient was brought to Sri Satyasai Hospital at Bangalore, and the mother said that she underwent an angiogram to her right groin. And after the test, the mother was informed that the test wasn't successful and it was too risky to proceed with surgery, is what the mother informed me. Hence, she was started on certain oral medication and was asked to remain under follow-up. However, the patient did not follow up and he presented over the next 2 years, the mother also noticed that her child frequency of lower respiratory tract infection went down. She remained stable and gained weight for a few years. Until last couple of years, where she started experiencing palpitations or insertion that subside at rest, they were regular in nature, not associated with sudden onset or offset, not associated with pre-syncope, not associated with post-palpitation menstruation, and not associated with shortness of breath. She also complains of fatigue, but there is no history of orthopnea, DNE, no history of fluid discoloration of lips or oral mucosa. There is no history of spotting episodes in the childhood, no history of headache, no history of cough or blood in sputum. There is no history of prolonged fever, no history register of tuberculosis or acute rheumatic fever.
Very good description of the history. You can give one of the good descriptions of the history. From childhood onwards, you can know the complaints for the last 4 years. You can better to start from the childhood itself. Very good.
Can I proceed? Can I include the family? The patient is born out of non-consanguineous marriage. Her father is first, and she has a younger sibling who is a brother of 7 years old, who is alive and healthy. She has attained menarche at the age of 14 years. Her last menstrual period was on 18th of October. It was regular, and there is no history of menorrhagia or dyspnea. There is nothing significant in her personal life.
There's nothing.
I wanted to rule out.
I was hoping that there was something.
Well, I just wanted to complete the.
Can you sum up and give us your impression?
So I have a patient who is a 19-year-old adolescent female menstruating. She presents with complaints of palpitations and fatigue and has a significant history of lower respiratory tract infection in her childhood and failure to thrive. Where there was a period of where she settled and then she worsened in her adult. So I would like to present my intervention. So my differential diagnosis at the end of the history would be a cyanotic congenital heart disease. Likely a cyanotic congenital heart disease with a significant post-tricuspid shunt. Probably a large PSC, a large PDO or a ACC.
But she was evaluated initially and told that there is a hole in the heart, but nothing needs to be done.
Yes, sir.
What is that? There are two, red herrings in her history. One is that she was told that nothing needs to be done. And the second, after the cat at the Institute of Refuge, she was told that surgery is high. So now can you analyze this? Which particularly the second part, which surgery would be too high risk in a body of which post tricuspid shunt would be too high risk?
It was a large PSC uh, with uh, evidence of PAH. The closure of the PSC would be to have undergone an angiogram with a CAT study at that point, which would suggest that it was not an operable physiology at that.
So who can believe that? It must go like you won't record anything and second one is for the highest. But why will be? First you told that you don't record anything.
Yes, sir.
Then second part is that you can surgery for the highest.
First at Durgapur, they said that she will require a test, so she was referred here. And after the test, they said that doing any surgery would be risky. So they started her on certain oral medication and asked her to remain at follow-up.
Which one would you believe? Nothing need not be done or nothing cannot be done.
Nothing need not be done at that moment because I'm suspecting if it's a post-tricuspid shunt, most of the VSC the doctor would be expecting it to close. If it's a moderate VSC, then they close up to 50% at the rate.
What are you so who can believe?
Which one is more trustworthy?
The second, I mean,
Naturally.
because the CAT study.
Present in the same institute.
Yeah.
So,
CAT study.
and obviously the answer is a no-brainer. You should just say yes. The second one is more likely.
You said the child gets a respiratory tract infections come down, AIDS came down after some time.
Yes, sir.
So in a post-traumatic situation, what are the situations where the patient improves?
If there is spontaneous closure of the shunt.
Okay.
Second, if there is onset of significant pulmonary hypertension, which reduces the pulmonary blood flow, can also reduce the shunt.
And there is probability of obstruction from where that's only.
Vascularization can also.
So the situation where they will permanently improve.
But none of them explains that surgery would be high risk.
Right.
Yes.
None of this situation. Can you consider any other shunt which would be high risk for closure?
You just consider high risk for life.
The other interpreted it as was risky to go ahead, so I interpreted it to be that the closure was not that by. It was not clear to me.
Okay, can you, let me put it another way, can she have a condition where the flow is high, there is a history of recurrent respiratory tract infections, there may be some cyanosis which may be missed because it may be mild cyanosis, and that surgery is a little high risk at 5-6 years of age, and thereafter she develops PA and the symptoms.
Increased pulmonary blood flow.
English one. Presenting like like an acyanotic shunt lesion, post tricuspid shunt, but it's actually an admixture lesion.
Maybe cannot require. No, sir, PSC.
PSDPGA is an admixture lesion.
So you are saying that there is increased pulmonary blood flow.
Increased pulmonary blood flow.
Right side.
There may be cyanosis, which may be. See, now you have the fact is that you trust that she was told that surgery is high risk, and you believe that this was a true statement. So therefore, you are obviously not dealing with plain shunt segment. But you are not dealing with standard BSD. See, if it was BSD severe PH, then they would have been told it's inoperable, right?
Yes.
Why would they be told that it's sinus? So I'm trying to probe a lesion which is associated with height. There may be some sinuses in this.
Please say it again. Uh, It can be,
Some examples can be given and explained. Some examples of definition.
admixture. Yeah,
What are the three ways in which sinuses can happen in a vagina? There are only three to talk.
increase,
What is top?
is, talk with the cyanotic constituent rapidly reduced urinary blood.
No, what causes sinuses in top?
The shunt which is, right to left.
Right to left. So that's one. What is PGA?
TGS transposition,
No, what is the physiology in PGA?
but there is the pulmonary arteries arise from the systemic,
It's called parallel circulation.
parallel circulation.
It's not a series circulation. It's a parallel. The third is admixture lesion. Now, what is admixture lesion?
What are levels can the admixture occur? Cell and exam. What is combinatory? Combinatory second admixture lesion. Combination, not one trial. You are doing very well. Okay. So patient will prove that 5 years and W cap, you are started on contract, what to pay the track?
Form of microbiological.
That was on 10 years back. One crore.
Pulmonary vascular. So I'm respecting a post-transmission, large disease. Yes, large baby, large baby or a large baby.
You know that weight like.
Three types,
I not that weight.
prescriptions are given the restricted presented first very early in childhood. Whereas in pre-prescription, they present later, maybe in second decade of life. And the onset of, even though they do have increased early blood flow, the onset of early hypertension is late. And whereas in post-prescription, they have history of frequent LRTS, failure to thrive is most predominant that we have in this. We would have designated with sinuses at birth, which is not.
Then you won't get.
When early sinus have happened.
You won't get. 8%, 9%, 7%.
Once, like early, like 2 weeks, there can be sinuses.
The PAPDC acts like which contribution? Which sinus?
I didn't know.
Sir is asking about admixture physiology.
The PAPDC acts like which contribution?
Admixture physiology.
It
Okay,
can increase,
have you defined admixture lesion?
like respiration.
One new increase in the green one. Please,
In the chamber of mixing,
Mike. Go.
at least same or they can't be exactly the same. Yeah, so what's the cutoff? Cutoff of difference is from here?
He presented actually.
Yeah, I mean, this one, here or MS?
Increase that.
Downstream the chamber of mixing, all saturations will be in around 5%.
Yeah, within 5%. Within 5% of each other. So now can you just list out the admixture lesions starting from pulmonary veins?
I guess, total, PAPVC, the chemical is lightning cleans. And downstream is all.
No, that depends on where, it could be common, like common check burning, common drain.
Okay,
Okay, but anybody, TAP is pulmonary vein level.
It's a piece with, like, try to see at least, yeah, no, next, come to the next level, no, come from that over, so that you will not. Permanent drain, no, next. Then,
Ventricular level.
Then you were saying tricuspid increase, that is right, tricuspid increase. Yeah, correct. After that, in the ventricles, ESD.
that's a bit completely,
Single ventricle. And then at the great arterial level. So can this patient be like now, we've arrived at Ranthas in a very circuitous route. But you are considering all the factors. That there was a patient with recurrent respiratory infection. He was told to, he underwent a CAT. CAT was deemed to be very high risk. At what age does Ranthas become relatively harmful? Or in other words, by what age should Ranthas get operated? As we- So now retrospectively, can this all fit in with Ranthas? Why?
She doesn't, she has tolerated the lesion very
We
well.
will send this one to.
And she does not present with,
I have this number.
like, the features of sinuses, and the failure also started after 6 weeks of birth.
I'll send it back. Send this to the top.
In her symptoms, she was stable at birth,
Tell that.
started having features of failure to thrive and LRTI after few weeks of birth.
Anemia has to form.
I'll minimize it.
Because having recurrent respiratory infection at what age?
He started having respiratory tract infection